Good evening.
Yeah, hi. So give me one moment. Yep, I'll share screen. Nikhil, I'll just remind you, just let me know when there's last 5 minutes remain.
Yeah, sure. Yeah.
Yeah, I'll start a timer at my end, but make sure you keep time at your end too. Okay. Sorry about that. Just fix it a bit. Yeah, you can start.
So I'm presented with the frontal radiograph of chest of a skeletally mature patient. I can see that there is a well-defined radio opacity in the right middle zone, in the right lower zone. It has some internal heterogeneous calcifications. There is some low density also seen within the lesion, and there is mild surrounding consolidation. The underlying rib appears normal. I cannot see any other lesion within the rest of bilateral lungs. The bilateral hyla and the cardiac silhouette is normal. The bilateral hemidiaphragms and CP angles appear normal. I'm looking at the bones. I do not see any other significant bone lesion, and the infradiaphragmatic regions are normal. So in summary, there is a well-defined radiopacity in the right lower zone with some calcifications and some low density areas within. The possibilities would include calcified granuloma like tuberculoma, or if the patient is immunocompromised, a fungal granuloma. Also, it could represent a pulmonary mass like a hematoma. Apart from that, I would like to consider an AVM because it is perihilar in location and has some heterogeneous calcifications within. So these will be my primary differentials, or lower down my differentials, I would also like to keep metastasis. And I would inform these findings to the referring team and would compare with the previous radiographs of the patient to see for the progression of this finding. And I would also check the previous medical records for any history of infection or any previous prior malignancy in this patient. I will inform these findings. I will also evaluate this patient further by CCT of the chest to characterize this finding. And this patient will be referred to the pulmonology and an MDT with an MDT discussion to decide the further course of management.
Okay, you give a pretty long list of differentials, but if you had to choose one of your as the most likely, what would you think?
I would think because it has some calcification, low density, I would think a hematoma maybe, or a calcified granuloma. That would be my top two differentials.
Okay. Most of the is there anything else that you can think of apart from the ones that you've discussed?
It could be it could be some lesion along the pleura or the chest, like though I cannot see any fracture in the rib, it could be a healing callus in the rib, or it could be some calcified pleural plaque that is located on the anterior aspect or the posterior aspect of the chest and is projecting as a lung nodule, or it could be.
Okay, so if that is what you think it could be, what would be the next step?
I would do a lateral chest X-ray to see actually what is the location, whether it is a lung lesion or a lesion located along the anterior or the posterior chest wall.
Okay,
And
but then you've already mentioned that you would like to do a CT, so I'll just show you one sequence from the CT, which was actually done in this case.
so I can see that there is a lesion that is exophytically arising from the fifth rib and is projecting inferiorly. So this lesion appears to be an osteochondroma arising from the rib. And And this is, I will inform these findings to the referring team and will refer this patient to the orthopedic department, as well as with the MDD discussion regarding the further course of management.
And apart from referring it to orthopedic, is there anything else that you would like to think about from an imaging perspective?
From an imaging perspective, I would further characterize this. I would do a bones a bone scan maybe to
What would bone scan add in this?
sorry, a MRI would be done to see for the cartilaginous cap, the thickness of the cartilaginous cap to if it is if it is more than 2.5 centimeter, it might represent a malignancy. And also to see for any bone marrow edema or any fracture if the
Okay,
patient.
okay, we'll just go on to the next case, okay? Here you go.
So I'm presented with the frontal radiograph of the pelvis of a skeletally mature patient. The striking finding is the hypoplasia of the right side of hemipelvis with the demineralization on this side. Also, I can see that the right proximal femur is also attenuated and hypodense. And actually the whole hemipelvis, including the pubic bone and the ischial bone, appear hypoplastic. I can see some degenerative changes in the right hip joint with few osteophytes and reduction in the joint space, and similar degenerative changes are seen on the right side as well. Apart from this, I cannot see any other significant lesion within the visualized bones. Some degenerative changes are also seen in the at the level of the lumbar vertebrae with the significant osteophytic proliferation along the facet joint of the L5 and S1 vertebrae. So, and even the muscle bulk on this side appears reduced. So the possibilities in this case would be that of a neuromuscular disorder affecting this side, like poliomyelitis or some hereditary neuromuscular disorder with the secondary attenuation of the bones. And it would inform these findings to the referring team and would compare with the previous radiographs. And this patient will be referred to the neurology and the orthopedics department for further management and an MDT discussion regarding to decide the further course of management in this case.
Okay. So you can ask for control. I'll give this to you. This is a 1-year-old patient.
Okay.
Here you go.
So I'm presented with the chest CT scan, contrast enhanced CT scan of the chest of a 1-year-old child in lung windows. I'll first scroll through the scan to see the findings. So I can see that there is a destructive lesion along the right paravertebral space, which has some internal calcifications within. There's some internal calcifications within. It is abutting the vertebral bodies with causing mild erosion, causing focal erosions. I've lost control. Causing focal erosions, and it is also extending along the pleural surface. There is also some erosion of the adjoining ribs. The lesion is also abutting is also extending into the posterior mediastinum and extending into the lung extending extrapleurally into the hemithorax with atelectatic changes surrounding it. There's no fat density within. And and there is some neuroforaminal extension along few of the vertebrae. Apart from this, there are no other nodules in the bilateral lungs, no areas of consolidation. In my routine practice, I would also evaluate this lesion. I would also evaluate this case on mediastinal window to see for
Can
any.
you let go of the mouse once? I'll just give you the mediastinal window that you wanted.
So these are the mediastinal window non-contrast images, which show that this lesion is predominantly hypodense with some hyperdensity in the periphery. And there is no significant there's no significant lymphadenopathy. There's no significant lymphadenopathy, and there's no chest wall, no other soft tissue lesion. So, and the visualized abdomen, this lesion is also extending retrocrurally into the abdomen. The bilateral adrenals are normal, and the for the lung, for metastasis, I would like to evaluate on the contrast enhanced scans, but on these non-contrast images, I cannot see any obvious
Which plane
focal.
in contrast enhance would you prefer, axial, coronal, or sagittal?
5 minutes remaining.
Coronal, axial, coronal,
Just
coronal.
let go of the
Coronal.
mouse and I'll give you what you want. Here, you go.
So on the coronal scans, I see that the lesion is retrocrural and having broad base towards the pleura. There are no metastatic lesions in the visualized abdomen. I would also look for lymphadenopathy in the celiac location, which I cannot see. And I would also look at the bone windows to see for any bony metastasis or any bony, also characterize a bone erosion. So
Okay.
in this case, my possibilities would be that of a neuroblastoma, considering the calcification, the paravertebral location. And the second possibility could be that of a paraganglioma rising in this location. And it could also be a pleural-based tumor, like a inflammatory fibroblastic tumor. And lesser down, I would like to keep metastasis from another location, like a rhabdomyosarcoma metastasis. However, that would be low down my differentials, and I would inform these findings to the referring team. I would compare with any previous imaging of this patient, and I would recommend further evaluation by a MIBG scan, which will help to characterize this finding. If it is a neuroblastoma, it will be bright on MIBG scan. And I would refer this patient to the pediatric oncology with an MTT discussion regarding the further management, and also to plan for biopsy in a bone sarcoma center.
Okay. Here you go.
So I'm presented with the frontal radiograph of the abdomen of a pediatric patient. I can see that this is a barium, lower GI barium study, which shows that there is pneumoperitoneum. This gross pneumoperitoneum. This is an urgent finding, and I would inform this immediately to the referring team. This patient will need an urgent intervention.
Are
Also,
you sure about the pneumoperitoneum?
This could be distended buccal loops, but this could be distended. I do not see any air fluid level, but it appears to be a pneumoperitoneum. The whole of the abdomen is filled with these gas shadows, and
What sign of pneumoperitoneum do you see here?
the football sign, maybe the whole thing is dilated and filled with air. Also, apart from that,
Is there anything else that catches your eye?
so there are multiple filling defects. The colon appears small in size, and there are multiple filling defects seen within the entire colon, reaching up to the terminal ileum. Because of these multiple filling defects and the small caliber, I'm thinking of meconium ileus, which happens because of a ileal atresia, or because of cystic fibrosis causing stenosis of the distal ileum. I would inform these findings to the referring team, and would check the previous medical records of this patient for any history of I will check the previous records, and I would recommend further evaluation by contrast enhanced CT of the abdomen to look for other findings of cystic fibrosis. And apart from that, I will also refer this case to the pediatric GI team, as well as the surgical team, for further management of the ileal obstruction and with
Okay.
an MD discussion.
You have control.
So then presented with the
Just click once and you'll have control. Yeah.
okay. So I'm presented with the non-contrast CT of the head. I see that there are hypodensities within the bilateral periventricular white matter, which appear to be edema. There is a lesion with central hyperdensity in the right frontoparietal region
Time up,
with
time up,
surrounding edema.
time up. Yeah.
Yeah. The time is up. Okay. So you wanna go next, Nikhil? I'll just
Yeah.
stop.
Yeah.
What am I doing wrong? Give me one moment. Yeah.
Check just a second. Yeah. Are you able to see the screen, candidate?
Yes, yes.
Yeah. Okay.
Okay. So I'm presented with the I'm presented with the lateral radiograph of the knee of a skeletally mature patient. The glaring finding here is the presence of a permeative lytic lesion in the, can you just give me 1 minute? Switch off the chat. I'm presented with, so there's a permeative lytic lesion in the distal diametaphysis of the femur with the causing bony destruction and extension into the soft tissues. There is complete erosion of the bony cortex, and there is a ring and arc type of calcification or matrix mineralization within this lesion. Also, this lesion has a wide zone of transition, though it is not extending into the joint cavity, into the up till the articular margins. And there's no bony sclerosis around it. There is a irregular periosteal reaction as well. The rest of the bones, they appear normal. So my possibilities for this lesion in a skeletally mature patient would be first a primary bone tumor like a osteosarcoma or a chondrosarcoma. Secondly, I would like to consider the possibility of a metastatic lesion, though that would be lower on my differentials. And also, I would like to consider infection also would be lowered on my differential, though because I cannot see any lamellar periosteal reaction, but that would be also one of the differentials. So my primary differentials would be osteosarcoma or a chondrosarcoma and an Ewing sarcoma arising from the bone. So I will inform these findings to the referring team and would compare with the previous radiographs of this patient. I will also evaluate this patient further by an MRI examination to characterize this lesion, and would also see this lesion on the orthogonal views to see for any other finding. Apart from that, this patient will need referral to the orthopedics department and the oncology department with the MDT discussion regarding the further course of management and to plan the biopsy in a bone sarcoma center.
So you gave me three differentials, osteosarcoma, chondrosarcoma, and Ewing's. What do you think the age spectrum is in all the three conditions?
So Ewing's is more of a young osteosarcoma and Ewing's would be there in a young patient, but chondrosarcoma would be in a slightly patient of a 30 to 60-year-old age group. But the presence of these ring and arc type calcifications could be because of an osteosarcoma which has developed in some prior chondrosarcoma that has developed in a prior cartilaginous lesion like a enchondroma or a osteochondroma.
No, you told me this is a skeletally mature patient, right? So would you still keep Ewing's higher up? Would you still consider Ewing's?
No, Ewing's would be lower down my differential.
Where do you think Ewing's starts? Which part of the bone?
Ewing's would be in the diaphysis. So this is a diaphyseal lesion. That's why I included the diaphysis, metaphyseal lesion.
Okay.
So I included Ewing's in my differential. But the primary involvement is of the metaphysis. So osteosarcoma is the primary differential.
What is the role of MRI in this case?
MRI would help to characterize any skip lesions, any joint involvement, neurovascular bundle involvement, soft tissue involvement, and
What is
that would.
What is skip metastasis?
Skip metastasis is a lesion that would be there in the same bone, some distance apart from the lesion. There would be normal fatty marrow between the lesion and the another lesion that we see.
In the
So
same
that will
bone? Is it necessarily in the same bone?
in the same bone or the adjoining bones, but not very far off. If it is in the other limb or other part of the body, it would be a metastasis. It has to be in the adjoining to the lesion in the same bone or the adjoining bones.
So what is transarticular metastasis?
Transarticular metastasis would be involvement of the joint cavity. There will be synovial thickening and
Okay. So
synovial.
in this case, if you were to say skip metastasis, what would you tell your technician? Would you tell him to?
I would include the one joint proximal and one joint distal to that lesion, so as to see for skip metastasis.
Okay, this is your next case. You can ask for control.
So okay.
So this patient is a pediatric patient presented with swelling in the face.
Okay, face. So I'm presented with the MRI of the neck in T1 weighted images of a skeletally immature patient. So on the T1 weighted images, I see that
I would make it easier for you. The swelling is on the left side.
okay. Swelling is on the left side. So
the swelling is on the left side of the face. You don't have to go down.
yeah, so I see that there is a lesion along the anterior aspect of the mandible.
That is normal. That is normal.
Apart from that,
look for any asymmetry on either side.
there is some preseptal soft tissue swelling on the left side.
You can ignore that. You can ignore that.
There is the left parotid gland appears enlarged as compared to the left side.
Okay.
And though the signal appears normal,
Okay.
and this is reaching up to the submental location, there is no, I cannot see any abnormality within the left parotid. There is no surrounding fat stranding. Both deep and the superficial lobes appear enlarged, but I would further evaluate this on the T2 weighted or the T2 weighted fat sat images to see for any pathology. So on the T2 weighted images, I see that there.
You wanted a T2 weighted fat sat? I have a T1 weighted fat sat. Is that okay?
Yeah, both will be.
Okay. Just can you leave the mouse once? Can you leave the mouse?
Yes.
Yeah, this is the T1 weighted fat sat.
So on the T1 weighted fat sat images, I see that there is no fat density within the lesion. I would like to evaluate this on the T2 weighted images, T2 weighted.
Okay, yeah, you can leave the mouse. You can leave the mouse.
So on the T2,
this is T2.
so T2 weighted, the lesion shows hyperintensity, diffuse T2 hyperintensity. There's no invasion of the surrounding muscles or the bones. They show normal signal. There's no surrounding fat stranding. And there's no lymphadenum.
Where do you think the lesion is arising from?
The lesion is arising from the left parotid gland only and is extending.
Which part of the parotid gland?
It is a superficial part of the parotid gland the lesion is arising from.
Okay.
And the shape of the parotid gland, and it's causing compression of the rest of the parotid gland medially.
Okay.
So my possibilities, I cannot see any flow voids within the lesion.
Are you sure?
And there are some flow voids within the lesion.
Okay.
So I
What
would
would
like
you?
to evaluate this patient on a contrast enhanced scan to look for the enhancement.
Sure, sure. You can leave the mouse. You can leave the mouse. This is the post contrast.
In the post contrast, the lesion shows intense enhancement. The only possibility I can think of in a young child would be that of a hemangioma. So I will inform these findings to the referring team, and I would compare any previous radiograph, any previous imaging, any previous ultrasound or previous imaging available. And I would refer this case to the surgery, pediatric surgery for further management.
Any other
And with an
differentials? Any other differentials that you can think of?
So it is most likely a hemangioma, but other possibilities could be soft tissue tumor arising in the subcutaneous region,
Okay.
and intensely enhancing or intensely enhancing metastasis, like
How
some
common is
paraganglioma.
how common is parotid metastasis?
It's very uncommon, but that would be very low down my differential. My primary differential is a parotid hemangioma.
Okay.
So
What if I tell you that this patient also has a posterior fossa malformation? Would you think of anything?
I would think of a
Not in
Farsis
this case.
syndrome,
Not in this
Farsis
case.
Last
syndrome,
5 minutes, guys. Last five
Farsis,
minutes.
Farsis syndrome, which
Okay.
has
So what are the components of the face syndrome?
face syndrome will have posterior fossa malformations, hemangiomas, enorectal malformations,
We can leave the mouse. We can leave the mouse.
and choanal atresia, and ear anomalies.
Okay.
I'm not sure.
This is your next stage. You can ask for control.
So okay,
You can scroll. You
I
can you can scroll.
I have the nuclear medicine. I think this is a PET scan or
Okay.
a PET scan of the skull in the coronal views, which shows that these are CT images, which show that these are the fused images, which show that there are erosions along the articular margins of the left temporomandibular joint with widening and broadening of the bones and narrowing of the joint spaces and marginal osteophytes.
Okay.
This represents changes of osteoarthrosis in the left temporomandibular joint. The right joint appears normal. And I would also evaluate this on the orthogonal images to look for any loose bodies or any other findings, and also on the soft tissue windows to look for any synovitis.
You can leave the mouse. You can leave the mouse once. Yeah. This is the window for you. Yeah.
So these are the bone windows of this patient, axial CT scans, which show that there are some periarticular.
What is the diagnosis?
It is a TMJ osteoarthrosis.
Okay. Do you know the treatment? Are you aware about the treatment?
Treatment would be a replacement prosthesis if the patient is very much symptomatic.
Anything before that? Any medical management? Any intra-articular injections that you're aware about?
Steroid injections
Okay.
may be done to relieve the pain.
Okay. You can leave the mouse. This is your next case.
So this is the T2 weighted MRI of the abdomen. I can see that there are bilateral small pleural effusions. Apart from that, there are incidental renal cysts in the right kidney. The liver appears very much hypointense, and also all the muscles and the bones and the pericardium as well, and the liver, spleen, the pancreas is not visualized.
Okay. Do you want to see any
Pancreas
other
is not
sequence?
visualized.
Do you want to see any other sequence?
I would see the T1 weighted images.
No, yeah, you can leave the mouse. You can leave the mouse. I can give you another T2 weighted sequence. One second. Yeah, you can appreciate all the organs in this.
So yeah, the liver and the um, liver spleen appear normal. The gallbladder is normal. The bilateral kidneys are normal, and the pancreas. I can see only the head of pancreas. The rest of the pancreas is not visualized.
So what do you think?
Likely agenesis of the pancreas, because I cannot see the pancreatic duct as well.
Okay.
So we don't, apart from this, I cannot see any other abnormalities. There is no evidence of malrotation in this case.
So what would you like to do next?
I would inform these findings to the referring team and would compare the previous imaging if available, and would do a MRCP scan to
What are the
MRCP.
what are the things that I should be worried about in this case if I put this patient on a follow-up?
Pancreatic agenesis might be associated with other congenital anomalies like
then
malrotation.
yeah, okay, malrotation. Yeah, okay. Next.
Also,
Then I would pick up
patient have developed
malrotation.
pancreatitis.
Yeah, I would pick up malrotation in the current imaging as well, right? Something which I can foresee in the near future if I follow up this patient, something that can come up.
So I cannot see the. I can see the loop of the third segment of duodenum crossing to the left side of the pedicle. So I don't think
That
there
is
is any.
fine. That is fine. That is fine. Absolutely fine. Yeah.
So any annular
That's fine.
pancreas.
Your time is up. It's fine. It's fine. Thanks. Yeah, your time is up. So Dev, do you want me to discuss first and then?
Continue with your feedback, then
Sure.
I'll
Yeah.
yeah.
So, hi, candidate. I think you did pretty well for my cases as well as for Dev's cases. I'll give you feedback for my cases first. So this case was a case of dorsal pancreatic agenesis. Okay, it's a it's a rare normal variant that you can see sometimes, abnormal variant. Sorry. And a common question that can come along with this is these patients are often presented with hyperglycemia. And remember that in future, these patients can be prone for pancreatic tumors like solid pseudopapillary tumors. And like you said, pancreatitis can also present in these cases and intestinal malrotations. Okay. So it was just a kind of a spotter case that I wanted to show you to see if you can pick it up. This case, you were spot on. This was a case of a TMJ osteoarthritis on the left side. Sometimes they can show you a PET image to begin with, and that should not take you off track. You should stick with what you are seeing. And in your case, you were very precise in looking at the underlying bones and picking up the subchondral cyst and the degenerative changes, and then you connected the dots with the PET scan. I think you did really well on this case, and you did not panic. Oftentimes, when people get PET scans, they panic, but you didn't, and you correlated with the bone window scan, and then you picked up the diagnosis. Treatment is intraarticular injection with hyaluronic acid and corticosteroids, and if they are resistant to it, then they go for the surgical management. Okay, so always think about medical management first, and most of the cases it would be steroids, so you would not go wrong. So think about medical first and then go for the surgical side. Okay.
Okay.
This case, very good. You picked up all the findings. You initially, I think you were a bit confused where the lesion was. That can happen in the real exam as well. So do not panic. Go step by step. Look at your check areas, and then you can pick up the lesion. Initial scan, when I gave you a T1 weighted, you picked up there was a bulkiness on the left side, which was good way to pick it up. And then on T2, you picked up the lesion. Remember, do not say something unless you're very sure. You said there was no flow voids. In fact, there was flow voids right from the T2 sequence, right? Uh,
Right.
so be very careful when you're using the words, okay? And in contrast, you were very spot on. And in such cases, it's always good to stick with one diagnosis, but just in case, okay, always put in differential, like, and say that this could be less likely, okay? Like in this case, you could say that it could be a vascular malformation. Still, you are on the safer side, right? Rather than committing it as a hemangioma, right? So you could say this could be a vascular malformation, but I do think that hemangioma definitely tops my list. And in a pediatric age, this is the most common tumor, correct? And you were
Right.
also regarding the phase syndrome, I think you got it a bit wrong, but that's fine. Please revise the entities because oftentimes these days in the exams, they do ask the
Right.
syndrome expansion. So it was posterior fossa malformation, hemangiomas, arterial anomalies, coarctation of aorta, and ocular anomalies. Okay. So remember
Okay.
the components of the face syndrome. Oftentimes when in the exam, you will get a case which is very straightforward, and don't make a mistake of messing it up. Always hit for a 6, and it kind of relieves your nerves also, right? So this was a very classic case. You described the lesion well, and this was a case of osteosarcoma. So when you say it's skeletally mature, avoid using Ewing's. Again, the site is metaphyseal, right? So I would say stick to osteo, and say oftentimes when you describe, say it as an aggressive bone lesion. Don't commit it as osteosarcoma right away. You describe everything and say that I think this tumor is most likely along the lines of an aggressive bone lesion, and I would put a differential of osteosarcoma, right? And then you say that I would put a referral to this bone tumor specialist clinic or a sarcoma clinic, and a plan for biopsy after discussing with the bone specialist, correct? And then skip
Yeah.
metastasis is quite a common question being asked for osteosarcoma. So like you said, you would also examine the bone adjacent to the joint, so that if there is any lesion in the adjacent bone, okay? So read about skip metastasis when it comes to osteosarcoma, and also just read about the types of osteosarcomas that you can see, okay?
Right.
Yeah. Thank you so much for participating.
Yes.
I'll just hand over
Thank
to.
you so much, Dr. Nikhil.
Yeah. Thank you so much. Yeah.
Yeah, Nikhil, can you stop sharing? Yeah, I'll just quickly go. Yeah. Okay. Yeah. Hi. Before we start with the specific, am I audible, right? Yeah, I'm audible. Yeah.
Yes, yes, yes.
About this case, I just wanted to tell you a couple of general things. You are adding a lot of differentials in many cases. If both in my cases and in Nikhil's, I noticed, and this is if you don't know what a particular case is, it's perfectly all right to just throw around 4 or 5 differentials. But if you know what this is, then I would avoid thinking of more than 3 differentials for 2 reasons. First of all, it sort of makes the examiner think that you are not sure about what your primary differential is. And secondly, when you try and think about the differentials which are much lower on your list, then you're listing of points in favor and points against, and that's taking away a lot of your time. So in this case, in the first part of your description, you did not think of something that could arrive from the chest wall, and that is okay. You can that's not something that pops up in our mind immediately. We always think about hamartoma first when we see something like this. But then you started going towards hamartoma, granuloma. Those are the honestly two differentials here. It very less likely to be any kind of cancer, but then those are the top 3. You can't really think about anything else unless you are thinking about a chest wall lesion, which you can definitely add. So that's the general piece of advice. Apart from that, this one, yeah, you did well to describe it, but you know the answer now, that this was actually an osteochondroma rising from the rib. And in terms of what to do with it, when I asked you that, you did mention the MRI and the cartilage cap. You could also add that you'd review the previous images to see how stable it has been over years or months or weeks, whatever. So this was good. I would give you a 5.5 on the X-ray, but a 6.5 on the CT, because there was nothing, because you got the CT right away. This one, very well done. 7.5 from me. Nothing much to add. It's a known case of poliomyelitis. And yes, you were right about the differential. Something like ALS or other neuromuscular disorder can also present like this. This is another case where I thought that you added a lot of differentials. No, this was not differentials. So you started with this one, and you said this was a contrast enhanced scan. So be very sure about what you're saying. The first lung window was actually part of the non-contrast scans, and then I gave you the contrast enhanced scans. So just be very careful about what you're saying. And also, you asked for the mediastinal window, but before you got it, you started describing how it has extension into the neural foramina, or if it is involving the bone, or if it is involving the I can agree with you that there is pleural involvement. You can say that, but for the bone and the neural foramina, you could it's better to ask for the mediastinal window and then talk about it, which you did. Is just that if you describe things in a wrong window, then it just sends a wrong message to the examiner that this is what you do in practice, right? So don't do that.
So I should just like mention there's a mass and then ask for a mediastinal window when
Yeah, exactly. Whatever you need to talk about on this window, like you could say that I'm looking at the rest of the lungs, there's nothing much else going on. I would like to look at the mediastinal window specifically to evaluate blah blah blah. What you did, which you did. Okay. And then you can, if they tell you that, because this is an opportunity, if they think that there is not much to be added from the mediastinal window, they will tell you that, why are you asking it? And then you say, oh, this is why, and they'll tell you this patient did not have a neural extension, or this patient did not have a rib involvement. And now you know you don't have to go through an entire new sequence to get that little bit of information, which ultimately is not adding to your diagnosis, right? So yeah, so you can save time that way. This was okay. So these are just dilated small bowels in the background. I mean, there is no regular sign. I mean, I know a football sign can appear like this, but it's not really a football sign. It's just dilated bowels. And if there is a concern for a pneumoperitoneum, I mean, you could have asked for a history. In this case, you could have just said that if this patient is presenting with, constipation or, absence of passage of stool or anything, then you would be thinking about something else. And then you got the diagnosis. So you will get, I'll give you a 5.5 here because you got the diagnosis, but you did worry a lot about pneumoperitoneum, which wasn't there. But apart from that, you could have spent a little more time describing it, that the entire large bowel is, smaller in caliber than you would expect it to be. You did describe the filling defects, and this is essentially meconium ileus. You got that right. Lastly,
so for further imaging of that patient, should we mention CT or something for the
meconium ileus? No, I don't think you need CT for meconium ileus. You could think of an ultrasound. You could say that I'll do an ultrasound, or in this case, you could have even said that I'll do a lateral. If you're really worried about pneumoperitoneum, then you would have seen these, and then you would have known that this is a dilated bowel. So we could always do a cross-table lateral view in infants in this age group.
Okay.
In the next case, you ran out of time, but so this happens sometimes when you get a case in the less than last minute, then you can run out of time. So there is a timer somewhere in there. So if you do think that you're nearing the end of the time, quickly go through the case and blurt out a diagnosis. If you think it's in the last 10-15 seconds, if it's right, then you get out with a 5.5 or a 6. Okay, but other than that, this is just I hope this doesn't happen, but yeah, that can happen. For Nikhil's cases, yeah, I think, the only fact that thing that I noticed was that you were giving a bit too many differentials, honestly. So just be more confident about your top 3 and stick to them. You don't have to add things that are not that relevant.
Right. What is this lesion that I wasn't able to complete?
Oh, this is a hemorrhagic metastasis, and from a primary, I think, breast cancer. It's random, normal. On post contrast, you would have seen the ring enhancement. On axial window, if you'd asked for it, you would have seen the skull metastasis. So okay. Well done. I mean, on average, you'll get a detailed score sheet, but on average, you're getting more than 6. So well done.
Okay, thank you. So differentials would be like hemorrhagic metastasis or cavernoma, or
in
on
this
the non-contrast.
After on the non-contrast, after you see this, though, I wouldn't really place a lot of importance on cavernoma.
But that would be cavernoma and some hemorrhagic metastasis or calcified primary brain.
This could be, hemorrhagic metastasis would be the primary, because what else would cause a hemorrhage like this, right? With multifocal hypodensities everywhere. I mean, without the hemorrhage, I would think about infection, maybe tuberculosis, but with the hemorrhage, I doubt it's anything else.
Yes. Thank you, Dr. Dev.
Sure.
Okay, so candidate B, are you ready?
Yes, sir.
Yeah, cool. Dev, you can start.
Oh, me again? Okay, cool.
You want me to start? Anything is fine.
No, I can start. I can start. Yep, sorry. Okay, time starts. Let's go.
Oh, I'm presented with the lateral radiograph of a right knee joint. I can see there is soft tissue swelling anterior to the patella and also anterior to the tibia. There is a joint effusion in the suprapatellar fossa. Otherwise, I do not see any lesions, lytic or sclerotic lesions in the femur or tibia or fibula. I do not see any fractures. So there is significant soft tissue swelling in the prepatellar region and joint effusion. I think this could be a prepatellar bursitis. There are some calcific densities. There are some calcific densities in the prepatellar region within the soft tissue. Okay, my principal diagnosis is mainly this could be a bursitis, a prepatellar or infrapatellar bursitis. I would like to do an MRI for this patient to confirm the diagnosis.
Okay, so before you do an MRI, this is an elderly patient who presented with a swelling in the knee, around the knee, as you noticed. Is there anything else that you can think about apart from bursitis? If I were to tell you that this patient also has a swelling around the elbow, will that help you? In fact, let me go ahead and show you. This is an X-ray of the patient's elbow.
Okay. I do not see any erosions in the bones. I mean, I'm thinking of arthropathy, inflammatory arthropathy kind of a picture, but I do not see any erosions within the bones. I do see some calcific deposits in the knee joint. I think this could be a crystal deposition disease.
Like
CPPD.
any other crystal deposition disease that you know of?
Gout is a possibility.
So what will you do next?
I wanted to do an MRI for this patient.
Okay. And other than that?
We can do an ultrasound and see and aspirate the, if it is a fluid, then we can aspirate and send it for cytology.
Correct. Okay. So how would you summarize the case?
So basically there is a prepatellar and in the anterior soft tissues of the knee joint, there is a swelling with some calcific densities. I think this could be a bursitis or an crystal deposition disease because of some calcific deposits. So I'll do an ultrasound guided drainage of this and send it for analysis. Yes, sir. I will inform this case to the referring doctor as well for further management.
Okay. So second one.
Okay. I am presented with a frontal chest radiograph of a skeletally mature patient. I can see there are multiple nodules diffusely distributed throughout the lungs. I'm just looking for the bones if there are any destructive lesions. I see the ribs are looking normal. The vertebrae are looking normal. I can see the left breast shadow, but I do not see the right breast shadow. So I think this is a patient who had right breast carcinoma post mastectomy status. She has presented with cannonball metastasis in the lungs. Yeah, I would just like to ask the prior history of this patient, and also I would correlate with prior operative records for this patient and do a CT thorax, abdomen, and pelvis to check for further metastasis and inform this finding to the referring doctor for further management.
Okay. Here you go. Oh, sorry. Here you go.
Okay. I am presented with a frontal chest radiograph of a skeletally mature adult. I can see there is an endotracheal tube which is in situ and it is in correct position. I see there is diffuse opacification involving both the lungs, but the CP angles appear clear. There is no evidence of pneumothorax. I'm just looking at the ribs. Grossly, the ribs look normal. I do not see the cardiac silhouette very well. So there is diffuse opacification in bilateral lungs, predominantly in perihilar location. Cardia appears to be normal in size, and there are no pleural effusion. I think this could be a diffuse alveolar damage. My second differential would be a pulmonary edema, and third, it would be if the patient is an immunocompromised, then I would think of pneumocystis xerovicae pneumonia also. I would like to do
Do you usually expect pneumocystis xerovicae to be this florid?
No, sir.
Yeah. Okay.
Or
Continue.
it could be a pulmonary hemorrhage also.
Mhm.
I would like to do a CT scan for this patient to further
Okay.
to further characterize this.
Yeah.
Okay.
If you ask for control, you can scroll.
Okay. Sir, I do not see the option of asking for a control in my.
Go up to the place where you see audio. Let me just pause the timer. Wait. Yeah, you see audio, video, participants, chat, and share, and goes right to that, and you'll see remote control. Right at next to annotate.
Okay. Leave computer audio. Okay. Sir, I see participants, chat, react, share, AI companion, apps, all these options. In the more also, I do not see any control option.
Okay, then no
Sir,
problem.
could you scroll for me?
Yeah, I'll scroll. Let me start the timer. I'll scroll for you. Yeah, okay. So I'll just scroll from the top to bottom. Yeah.
Okay. So I see there is endotracheal tube, which is in situ and in correct position. As you're scrolling down, I can see there are multiple ground glass opacities diffusely distributed in peripheral and perihilar location. Diffusely distributed in both the lungs. There is no zonal predominance or lobar predominance. I think this could be a case of diffuse alveolar damage, secondary to if the patient has had a history of toxic inhalational gases, this could happen. Or if the patient has like a drowning experience, then this could be the manifestation of that. Or this could be some toxic chemical ingestion.
So what is your final diagnosis? What would you call this? Diffuse alveolar damage.
Diffuse alveolar damage. Yes.
Okay.
Yes.
Okay. Let me just, I'm having some problem with the screen share. Just one moment. Yeah, okay. So this is your next case.
Okay, I am presented with frontal radiograph of the abdomen. I see there is a large distended bowel loop which is peripherally located, and I can see there are multiple small bowel loops in the central part of the abdomen. This peripherally located loop is mostly occupying the right upper quadrant. Okay. I think this is a case of sigmoid volvulus. I do not see any air within the bowel wall or pneumatosis intestinalis. I do not see any pneumoperitoneum or portal venous gas. So I suspect this is a case of sigmoid volvulus, and I would go ahead and do a CT contrast CCT abdomen for this patient.
Before you do that, what if I tell you that this is a neonate? Will that change anything for you?
Okay, this is a neonate. I do not see the rectal gas shadow, and I see there is a large distended bowel loop. So I think this could be a low intestinal obstruction, which and I think Hirschsprung's disease is one of the differential.
What else can it be?
Then it could be meconium ileus or ileal atresia also. No, sorry, ileal atresia will have microcolon.
And meconium ileus?
Meconium ileus also presents with microcolon, and it presents with yeah. So this is a
Will-
large bowel dilatation, and I think it most likely diagnosis is Hirschsprung's disease or an anorectal malformation is a possibility. I would like to do a fluoroscopic lower gastrointestinal study for this case to further evaluate.
Okay, so here you go.
Okay, I am presented with lateral radiograph of a barium enema study. I can see there is the contrast is passing into the large bowel, and the rectum is normal in caliber, but there is a gross distended sigmoid colon. So I suspect this could be a case of Hirschsprung's disease, and I would inform these findings to the referring pediatric surgeon, and I would advise a rectal biopsy for the tissue diagnosis.
5 minutes remaining.
Okay. You have you can't get control. Okay, so I'll just scroll from the top to bottom then. Is the speed okay for you?
Yes, sir. So I am presented with non-contrast enhanced CT of the thorax. As you're scrolling down, I can see there are, okay.
I'll scroll up again.
Okay. Yes, sir. There is left-sided pleural effusion. The esophagus, okay. Yeah, the esophagus appears dilated with, there is a nasogastric tube within the esophagus and endotracheal tube within the trachea. The esophagus appears dilated with air fluid level in grossly distended. There is a consolidation in the left lower lobe. Yeah, there is a consolidation in the left lower lobe, and I'm just looking for a defect in the I'm just looking for the defect in the esophageal wall, which could suggest this perforation and so can you go up a little bit?
Okay. Yeah, just let me know what you want. I'll do that.
Yeah. Okay, so I think the esophagus is dilated, sir, with air fluid level, and there is a pleural effusion in the left. There is left-sided pleural effusion with consolidation. But in my routine practice, I would ideally measure the HU of this to see whether it is a fluid or a blood. The esophagus.
This was fluid.
there
This
is-
was fluid.
There are some air pockets surrounding the lateral wall of the esophagus on the right side. I think this could be a case of esophageal rupture. Sir, is there a contrast study available? Oral contrast study available?
Yes, I was waiting for you to.
Okay.
Oral contrast? No, I just have
Oh.
intravenous contrast. Sorry.
Okay. Gastroesophageal. Okay. So I see that the esophagus is it's not stomach. Sir, is there a sagittal section or a coronal section?
Unfortunately, I don't have a sagittal section. I can give you a portal venous vein if you want, if that helps. But unfortunately, there is no sagittal section.
There is thick walled. The wall appears the thick end of the esophagus, and there is, okay. I think the stomach has herniated into the thorax. I'm not able to make out whether this is, I mean, this is a gastric, I suspect this is a gastric volvulus with intrathoracic herniation of the stomach.
Okay, so
Okay.
if you're thinking about volvulus, can you see the twist?
No, sir, I do not appreciate this twist.
Okay, so then what's your summarize this, please?
I think there is the stomach has herniated into the thorax, sir. I think this could be a paraesophageal hernia.
And how will you manage it?
Yeah, I would like to inform this to the gastroenterology surgical department. Yeah, for surgical management.
Okay, your time is up. Nikhil, you wanna take over?
Yeah, sure. Before that, candidate B, can you just check? There are 3 dots on the top of your screen. If you click on that, you can see request for control.
One. In this, you described this as a soft tissue swelling, but I wanted to see if you could, if you use the correct terminology. For instance, when you see these, always talk about how dense they are, even in the soft tissue compared to the other soft tissue, right? Because, and this is a good learning case, because gout, when they present with these tophaceous, almost mass-like lesions, they
Okay.
have these densities, which is quite dense. This is hyper dense compared to the other soft tissues. So you eventually got to the diagnosis of crystalline disease, but you needed significant help along the way. So this is a 5.5 case. Other than that, and the other clue was that, yeah, there's multiple joint involvement. So the patient has same finding, less prominent, although in the elbow, but you can see there is soft tissue swelling, which is quite dense compared to the associated muscles, surrounding muscles and fat, right? So this was a case of gout. This was very well done. This is an easy 7.5 for you. I would have, no, this is a 7 for you. I would have given you 7.5, but you need to focus on wrapping up a case. So you were very quick to identify that this patient has a mastectomy, and you explored the possibility that this is a metastasis. That was well done. But sort of spend some time, practicing your script, that after this, I will quickly review the previous imaging to see, I will review previous records to know if she's a known case of breast carcinoma. And then finally, I will recommend that this patient be discussed in the MDT. That's it. But you need to make it a habit that as soon as you finish describing the next 3 points about reviewing previous images, any other imaging if present, records, and then what should you do? Just make it a habit, because there are these very uncomfortable silences. And when that happens, the examiner typically doesn't step in, because this is a practice scenario. So we are always stepping in and giving you some history, some clue. But that can eat up a lot of time in the actual exam, because they're waiting for you to say something or do something. They don't know what you're thinking. So in those cases, I would say speak out what you're thinking about. For in this case, if you're thinking about, you're reviewing the bones, or if you're trying to look for a primary, I don't know, lung or whatever you think, just keep saying that I'm looking at the bones, I'm reviewing the infra-abdominal, infradiaphragmatic area. Just keep talking so that there are no silences, because they will not come and help you. Okay. Right. This one. Yep, this was what a case of ARDS, or diffuse alveolar damage, which could be due to secondary to anything, infection, near drowning, neurogenic. It can be anything. But when you see this, you did describe it the way it should have been. This is also 6.5 for you. But I was this where you mentioned the management? Yeah, even in this case, you did not place a lot of stress on how you would manage this. It doesn't end with just I would inform the referring physician, right? So this is the case. This patient is very sick, you can see. So this patient is probably in the ICU. So just you can say that you can comment on these things, that I can see evidence of this and this. It looks like a very sick patient, who's just show during your Viva that you are aware of all the clinical aspects. So this is a very sick patient. I'd be worried about this history. I'd think about aspiration or whatever else you're thinking about. Just make it a point to talk more about your thought process. Okay. This was a case of Hirschsprung disease. You did well in this. There is no problem in this. You even asked for the correct next step. You got it. Rectal biopsy. Well done. No problem. There's no issues with this one. Yeah, you struggled a bit with this because you were thinking that this is a esophageal pathology, but then you got there in the end. I agree. A sagittal or a coronal would have helped, but in this exam, they expect you to be, they expect you to be good at the axial and then ask for it, because we all know we don't report bowel or GI cases without looking at the coronal. It doesn't make
Coronals.
sense. We all do it. Yeah. So you can always say in my routine practice, I would review the coronal and sagittal, but based on the axial, you can trace the the nasogastric tube
Yeah.
and see that is coming in under the diaphragm.
Yes.
So it is definitely not esophageal pathology, and then the rest of the stomach is going up and
Up, yes.
yeah, so it's a paraesophageal
A
hernia.
paraesophageal hiatus hernia.
Yeah,
Yes.
yeah, hiatus hernia, which can or cannot present with a volvulus. I agree. In this, I don't think there is a twist, but it could have.
Mm.
Yeah, so I just, generally speaking, I would want you to, your speed is good, your clinical knowledge is good. See more cases, practice cases, the kind of cases that are seen in this exam, and practice wrapping up cases. You don't want, like, you even if you're struggling with a case, even if you don't know what's going on, just make sure that are there any emergencies? Did I address the emergency? If not, what will I do? Even in like a completely nuclear option that I don't know what's going on, I would like to, I have no idea what's going on in this case. Even that is okay, because then there is no silences. They will quickly skip that and give you another case. So what if you get a 4.5 in one case? That's okay. If you can score 6.5 and 7 in like 5 others, that's the average makes up for it. So just practice what you would do, what you can do in case things are really going south. This can happen to any of us. So just practice closing out cases. That's the best piece of advice I can give you.
Okay, sir. Thank you, sir.
Sure.
Yeah, thank you so much, both of you. I think both of you did really well. Keep practicing. And meanwhile, the rest of the candidates, if anybody wants to volunteer, please post your name in the Telegram group, and then we can schedule you for the coming sessions. Otherwise,
And please do not forget to leave us feedback. I see Nikhil has reminded you twice. Please do that for us. And the candidates who have already taken the Viva, if you fill up the feedback, we'll get your email and we'll quickly send you the the detailed summary of the scores and everything.
yeah. Thank you so much, everybody, for attending session. Hope to see you next Sunday. This coming Sunday, we have the next session. So see you then.
Oh, Nikhil, I did talk to, I wanted to give you some news. There is a consultant based in Northern England who wants to do a session on rapids for you guys on our, on our Zoom. So we'll announce the dates sometime in the last week of August, I think. We'll let you know. But so that will have some Viva practice as well as some rapids teaching as well. Okay.
Yep, that's great. They've keep us posted on that as well. Yeah.
Yeah.
Thank you, everybody. So we are ending the session. Thanks.